Good morning. Today we are with Dr. Marc Dersot from France, and we're going to talk about impacted canines. Jean-Marc is an excellent periodontist with a lot of experience on impacted canines, and we'd like to ask him a few questions. First, we want to ask him about the prevalence. In general, there is a prevalence of impacted canines between 1 and 3% in the general population, and it's 4 times more frequent in females than in males from the literature. And it's a family tendency we see in our patients. Sometimes siblings, they present the same situation. Would like to start with that question and ask you, how does that present in your practice, and tell us about your experience. I know you published data on over 1,000 impacted teeth. So please share out your statistic with us to start.
Okay, between 2010 and 2019, that means about 10 years, I have exposed in my private practice 1,048 impacted teeth. About 74% are upper impacted canine, and after there is a upper central incisor, lower canine, and second lower premolar, each of them about 4%. Among the 772 upper canine, 60% are on buccal, 40% are on palatal, 60% on female, and 40% on male. That is my data.
Mm-hmm. Okay, let me ask you then, we'll start with the palatal canine. How do you make your decision? What's your treatment decisions? And give us some comments on how do you decide if the canine is ankylosed or not? Give us some comments on when do you decide to place or not tats to start traction. And also give us some comments. I saw in one of your lectures the other day that you use sometimes a mini screw system developed by one of the French orthodontists to pull on the teeth. So share your experience with us.
Okay. So concerning the palatal canine, I always try to use the open technique. That means after an anesthesia, I open a full thickness flap. I don't make a hole, a plain hole. I really open a full thickness flap to accede to the bone. I eliminate a part of the bone around the crown, just enough to bond, but larger than enough, just enough to bond. And sometimes I eliminate also a part of the bone which is on the hypothetic trajectory of the tooth when the tooth will move. And before closing the flap, I make a hole in the mucosa. To avoid any hemorrhagic complication, because in this area it's the main complication, I use also sling sutures all around the hole to squeeze the small vessel and eliminate or reduce at maximum the option of hemorrhagic complication.
How do you decide also, I ask you, we've talked about this before, how do you decide if the canine is ankylosed? Do you take into account the CBCT? Do you look for the ligament? It's more like a tapping on the tooth to find if you have a dull noise or a sharp noise. How do you make that decision?
Except if on CBCT you see that bone is growing into the root, of course, definitely it's impossible to move the tooth. But if on the CBCT you see quite nothing, and when you at the percussion there is a sound noise on the impacted tooth, I think that there is a part associated with ankylose. So in those situations, I try to slowly, with I will say delicately, luxated the tooth without touching or the surface of the roots, the cementum, or without touching the cemento-enamel junction. Because I definitely think if I touch those areas, there will be an ankylose.
The other question is, how do you decide if it's more a full ankylosis or a small spot ankylosis? How do you make that decision?
For a photo, the reference is a pixel. For a CBCT, the reference is a voxel. And the voxel is huge in comparison with the size of the cells in the periodontal ligament. So sometimes on the CBCT, everything is okay. But when you heard the tooth, the sound is definitely associated with ankylose. So let's try, but sometimes it's without any succeed. Sometimes it's a failure, and the ortho cannot definitely move the tooth. It's a complicated situation, of course, and mainly when it is palatal. I think that maybe on the buccal side, it's quite easier to try to find a solution.
Okay, let me ask you, we're gonna concentrate first on the palatal and then we're gonna go to the vocal.
Okay.
Let me ask you on the possibility of damage to the lateral root. You know that we know from the literature that the follicular sac, sometimes it's in close relation to the lateral and can produce both from hydraulic pressure and from just from the sac itself. Can start damaging the root of the lateral. What's your experience in that sense? Share your thoughts. And how do you diagnose that? Do you diagnose it from the CBCT, or do you, because on the 2D images, you don't get to see it sometimes?
Of course, definitely. One of the interests to ask for a CBCT is to have a precise relationship in 3D about the crown of the impacted tooth and the neighboring roots. But if we think about the paper from Vince Cockich, he opened a flap, eliminate bone, realize a hole in the palatal mucosa, and close the flap. And he observed that there is a reorientation of the main axis of the tooth, and the tooth takes some distance from the adjacent teeth. In some situation, some referees ask me to insert mini screw tabs, and they think that it helped them to redirect the orientation of the traction and take some distance concerning the adjacent teeth. But if you see root resorption on the CBCT, and you think that you are able to insert the tooth in the dental arch, the long-term viability of resorbed root teeth are quite the same that the adjacent teeth with intacted roots. So I think that there is no major difference. Of course, if the entire root is totally resorbed and you have quite 2 millimeters in the bone, maybe the future of these teeth are bad. But in the great majority, even there is root resorption, only survey, maybe a splint at the end of the ortho. But I have several patients with root resorption, and the long term of those teeth are not bad in comparison with teeth with entire root.
Yeah, we talked about this before privately, but I want also you so you share your opinion. With the open procedure, we have less tendency to ankylose according to systematic reviews. We have also, it's better for the orthodontist to know the direction of the pull. Mm-hmm. So comparing open procedure versus closed procedure. And also some studies suggest that there is a reduced treatment time. What's your opinion on that topic?
Yes, definitely, the reduced time, because in some cases, I will say that at the beginning, when I exposed impacted palatal canine, I used the closed technique. And some of my referees phoned me a few months after because even with eye traction, it was quite impossible to the tooth to go through the mucosa. So I need to do a second surgery, operculization, just to make a hole. So one of the interests of the open technique is to avoid the second surgery if necessary.
Not only that, but if the device becomes detached, you can always retouch it. Plus, the orthodontist has straight vision, so you know how to put on the tooth.
Debonding is a problem if you use the closed technique, of course, because you need to do a second surgery again.
I would like to, before we go into to ask you a few questions on the buccal side, which is less prevalent, as we talked before. 80% of the prevalence is palatal, 20% of the prevalence of the impacted canine is buccal, and also only 8% are bilateral. What percentage of your cases do you see as palatal or buccal in impacted canines, and what percentage of your cases is bilateral?
On buccal, I have 60%, and palatal 40%.
Mm-hmm.
So it's quite different from the statistic you just gave us.
Well, my statistics are based, it's not mine, they're based on
literature.
From the literature, mainly from Erickson and Kurol, that they've studied a lot of it. And also there's papers by Bishara. Let me ask you on your, and by Thielander, on your population in general, what percentage of your exposures, of your 1,000 exposed teeth, which is a huge experience worldwide, give us the split, the statistics, what percent are canine, what percent are all teeth?
Yes, 74% are upper canine. I just have a look to the slide. So 74% upper canine, 5% central incisor, upper central incisors, 5% lower canine, and 4.4 for second lower premolar.
Mm-hmm. Do you see it more frequent, 3 or 4 times more frequent in females than in males, just like the literature says?
Concerning, yes, definitely.
Do you have,
the sex ratio is 60 for a female and 40 for male.
So it is the same like in the studies. Let me ask you this question. Let's go now to the buccal impacted canine, which is the more sensitive one, and because there's the issue with the attached gingiva.
Yeah.
How do you decide which procedure you're gonna do? When do you decide to do an apical position flap? When do you decide to do just a plain gingivectomy? When do you stage your procedures? When do you do first a closed eruption technique, take it to an area, and then do an apical position flap? Share your thoughts on that, because I saw your lecture and your cases are beautiful. And as you know, I have the influence, I'm an orthodontist, but I have the influence of my training with Dr. Van Arsdal, and he's the developer of the apical position flap. Yeah. That classic paper from the 77 with Marcel Korn, with Herman Korn in the AJO. So I would like you to share your knowledge. How do you approach the tissue?
It depends mainly on the vertical position of the buccal canine. When the buccal canine is low, the decision is about the amount of keratinized tissue on the buccal aspect of the crown. If there is a huge amount of keratinized tissue, a plain gingivectomy can be done only to expose a part of the enamel and to bond during the surgery or in another time with the orthodontist any devices. But it's compulsory to have at the end of the gingivectomy an amount of minimum 2 millimeters of remaining keratinized tissue. If with the gingivectomy you eliminate all the keratinized tissue, you will have a problem, a periodontal problem around the tooth. So when teeth are very low, or a plain gingivectomy, if there is not enough keratinized tissue, so the horizontal incision will be displaced a little on the palatal aspect of the crest, and I will elevate a partial, full and partial thickness flap just to be able to move the flap in an apical position on the crown of the impacted canine, just to expose a certain amount of the crown, and plain sutures to immobilize the flap. When the tooth are very high, just under the sinus or at the level of the nasal fossea, my strategy is to do a two-step surgery. So the first one, it is a closed technique. I open a flap, I eliminate, if it's necessary, a certain amount of bone on the buccal aspect of the crown, and then I bond an in-office device. I use a metallic button and a metallic wire with hole in it that allow the orthodontist to tract regularly in the coronal direction the crown. And when the tooth is in an enough low position, I do an apical position flap just to create a band of keratinized tissue on the buccal aspect of the crown.
Let me ask you, how do you modify your flap? And I saw it also in your lectures. Sometimes you do like a partial thickness flap, yes, and you mobilize it to one side or the other, yeah, just taking into account the future direction of the tooth, yeah, of the traction of the canine. Can you make a comment on that, please?
Of course. I will take the example of the crown of the canine when it is located on the buccal aspect of the root of the lateral incisor. My surgery will be an apically, but also a lateral sliding flap. I want to move a band of keratinized tissue through a pedicle flap, but the movement of my flap will not be exclusively vertical. It will be also with a mesial component, because I want to move the flap in the mesial aspect. So what is very important in the design of the flap is the vertical incision. They are not strictly vertical. The incision need to be a little vertical until the mucogingival junction is reached, and after, definitely in a mesial direction. That means that at the end of the surgery, the flap goes very smoothly on the crown. I don't need to tract the flap with the sutures. The sutures are here only to stabilize the flap. And those kind of surgery are totally the same when I use, I want to cover a root, for example. Among all the surgical techniques to cover a root when there is a root recession, one of these techniques is to do a lateral sliding flap to recreate a band of keratinized tissue on the root surface. So in the example of the canine localized on the buccal aspect of the lateral incisors, it's totally definitely the same design of the flap. So it depends of the position of the crown of the canine, or it is strictly vertical and I do an apically strictly vertical position flap, or it is a little on mesial and I do a lateral flap.
Okay, give us a little comment, and we talked about this before. On the panoramic X-ray, when you look at the canine, do you place it on the Kurol sectors, let's say sector 1 to 5? How do you decide when you need a CBCT? What's your imaging criteria for just better surgical approach? You've told me before that you look more at the crown. Can you share your knowledge on that, please?
Yes, of course. I ask my ortho referee to put their finger in the mouth of the patient and to look for a bump or on the palatal aspect or on the buccal aspect. But in a lot of percentage, even with your finger, you feel nothing. And personally, I cannot only on a panoramic say precisely where is located the crown. I see on the Facebook groups, people just only with a panoramic giving the exact position of the crown or its buccal or the palatal. Personally, I'm not able to do this.
Yeah.
So when I have, when I don't know exactly where the crown, I ask for a CBCT. But again, I will take the example of the canine located on the buccal aspect of the lateral incisors. When it is this case, the root of the lateral incisor is pushed on a palatal direction, and the crown is also pushed on the buccal direction. So in those localization, I don't need a CBCT. I need a CBCT when I have some hesitation about the localization of the crown. What is also the interest of doing a CBCT is to decide sometimes about extraction when there is too much obstacle on the trajectory of the impacted tooth, and it's quite impossible to insert the tooth in the dental arch. Extraction can be also the treatment.
Give us a comment also on your experience on the periodontal situation after the canine has been brought into the arch. We've read from studies, from some University of Washington studies before in the past, of different probing depth and different situations. Do you probe your canines and your laterals at completion of treatment? And how do you assess and how do you compare with the contralateral in case it was a single impaction?
I will say it depends mainly where the patient live. Some of my patients, it takes by cars or by metro 1 hour, 30 minutes only to come to my clinic. So it's quite difficult to ask to the parents to tell them, are you able to come to my clinic only for a few minutes just to probe? So when the patient live not too far from my clinic, I ask at the end of the treatment, the parents or the patient, if it is an adult, to come to my clinic and probe around the teeth. But it's not systematically, unfortunately. There is several papers about this subject. One of the latest I have read, but it's not maybe the latest, it's been done by Marc, who is at the head of the period department of Leuven University, not far from Brussels in Belgium. And all those papers say that in the great majority of teeth of impacted upper canine, the periodontium is quite the same at the adjacent teeth, but sometimes on the mesial aspect or on the palatal aspect, the probing is a little deeper, even if there is no pathology. But it seems that the epithelial junction is a little deeper in some area concerning those teeth.
Let me ask you, you've told me before privately that you work with 23 orthodontists in Paris, which is a huge number of referrals. That's why you have such a big data. Let me ask you now on more atypical cases, like the central incisors or the lower premolars. Also, give us a comment on the impacted lower second molars that many times it's just posterior crowding. That you have the third molars on top of them. Give us some comments on more atypical cases, on more, not only canines, take us through the different scenarios on the different teeth, okay?
In my paper, I have make a proposal about the surgical decision trees about concerning canine, but this surgical decision tree can be adapted to quite all the teeth. It depends mainly on the vertical position of the tooth. First, concerning the upper central incisors, some of them are quite horizontal, and I think that it's better to manage that situation with a two-stage surgery. That means the first surgery, the objective is to bond the device and to help the orthodontist to orient the tooth more vertically and to track the tooth more in a more lower position. If the orthodontist is able to direct the tooth and the eruption will be in the keratinized tissue in the edentulous area, I don't need to do the second surgery. But if at any time the tooth is able to go through the mucosa, not through the gingiva, through the mucosa, so I need to do a second surgery, apically positioned flap to move a band of keratinized tissue. And if during my first surgery, I was able to bond the device only on the palatal aspect of the crown, it will be easier after the second surgery for the ortho to bond the device on the buccal aspect. Sometimes there is odontoma associated with incisors, and I prefer to extract the odontoma and to bond the device mainly when the tooth is horizontal. I don't think that spontaneously an horizontal tooth is able to migrate and to correct its position and to have a vertical direction. So usually I try to do the maximum during the same session. I think that we need to think about, as a patient, what we prefer. And definitely, I think that as a patient, we prefer only one surgery, not 1, 2, or 3 surgery. At the end of the ortho treatment, what we can observe with young patients is a discrepancy between the eye of the crown of the impacted tooth and the eye of the crown of the neighboring central incisor. There is usually the crown on the impacted tooth seems higher. Of course, it is not a gum recession. What we see on the impacted tooth is the anatomical crown, and what we see on the neighboring central incisors, it is a clinical crown. But what we know is if we are able to wait, if we explain to the patient that with time, with growing, with maturation, the soft tissue will migrate in an apical direction, it's not necessary to realize a small gingivectomy, just to have the level of the gingival margin at the same eye. That is mainly the problems concerning the central incisors. You asked me about the second lower molar. There is so much localization. Some of them are totally horizontal. Some of them are, I will say, 45 degrees, and some of them are vertical, even if they are impacted. So the strategy is quite different. A few months ago, I attended the one-day lecture of Chris Chang in Paris, and I see that he liked to use a mini screw inserted in the vertical branch of the mandible.
Yeah, we use them in the Ramos. Yeah. I've done it.
I have no experience about this. Or I bond the device on the crown of the second lower molar. Recently, I tried to use a proposal from 2 French orthodontists, father and son, and they don't use mini screws, they use micro screws, and those micro screws are inserted not in the alveolar bone, but in the basal bone. So I have only one case, but if you want to go to the website of those 2 orthodontists, their name is Chilles, C-H-I-L-L-E-S. They have all the PDF of their papers. Unfortunately, those papers are at this time all in French. But even just looking the photos or the clinical cases, and you will see that they are able to move a second lower molar impacted, even horizontal or even at 45 degrees without extraction of the wisdom teeth. And we observe that they move distally the second lower molar, but the germ of the wisdom tooth move also distally. But there is a lot of proposal just to have a solution about those tricky areas.
Give us just, I would like to ask you one final question, not to take up more of your generous time. When do you decide that the canine or the impacted tooth in general it's not going to be able to be saved. It's very low in your statistics, and it's very low in ours. We tend to get them in the arch in a very large percent. I would say well over 98% of the time. But how do you decide when a tooth is just not savable? You know?
I will say that usually, and I'm sure that you have observed this situation, when you try to track, for example, upper impacted palatal canine, and after some months you observe that the neighboring teeth are ingressing, definitely I think that it is a sign of impaction, and if it is on the palatal side, I will decide it or to mobilize it or to extract it. When it is on the buccal side, I have only one case. So in the pyramid of evident dentistry, it's quite nothing. But a team from the Dental University of Montpellier, it is a city in the south of France, have developed a technique named orthodontic bone stretching. And through this technique, they are able to move ankylosed teeth. You know that a lot of children, when they fall down, they hurt the upper incisors. And in some cases, there is ankylose. And when you have to do the orthodontic treatment, you are not able to move the ankylosed tooth. And there is a discrepancies in the vertical direction. Though the orthodontic bone stretching is you use a piezo device, you open a flap, and you do a groove in the bone, 1 millimeter large and 5 millimeter deep, one on the mesial aspect, one on the distal aspect, and one on the apical aspect. And just after the surgery, they propose to use not only orthodontic forces, but orthopedic forces. That means more than 150 grams. And they succeed in moving those impacted ankylosed teeth. Of course, it is not the ligament, because the ligament doesn't work. It is the bone that stretch, and through this stretching, they are able to move orthodontically those teeth. So I had applied these techniques only in one case. It was a young lady, 14, and it was the upper left canine. So I used the closed technique, open a flap, eliminated a part of the bone. I bond a device with a metallic ligature, and I close the flap. And the tooth begin to move. But 4 months after, the referees call me, and he tell me the tooth stop. It doesn't move. So I try the proposal of the orthodontic bone stretching. I don't know if the tooth is impacted. I think that it is not, because the tooth moves. And definitely, if I was able to show you the photo of the first surgery and the photo of the second one, it moves. So I do a groove on the mesial aspect, on the distal aspect with a piezo, 1 millimeter large, 5 millimeter deep, and immediately after I have the ortho to tract. And fortunately, the tooth move, and he succeed to insert the tooth in the dental arch. So maybe it is an opportunity, an option, a surgical option, to move theoretically impacted tooth. But as I told you, I have only one case. So it is anecdotic. Even if it has a clinical value, it is anecdotic in comparison, of course, with a study with, like, say, 10 cases, and you are able to do statistics.
Exactly. Okay, so Jean-Marc, thank you very much.
It was my pleasure.
You are in depth to add with that book from Quintessence. You have to.
I am waiting for the definite okay of the edition, and I have to call the guy who in France is responsible about the books. So I decided to call him today. So after the end of our discussion, I will call him. But because of the lockdown, he's out of Paris, and I don't know exactly where he come back in Paris. But definitely, I will send you the letter to you and your co-author. And it's a very exciting idea to write a book with all my colleagues. I want this book to be international. A lot of people, not only Ortho, of course, Perio also. And I hope it will be a good book in all the literature. And for me, in 2 months, I will be 45. I know that I will retire maybe in 3 or 4 years. So I will be very glad if I end my practice with a book.
Excellent. So see you soon. Thank you very much. A big hug to France, and take care, and we'll keep in touch. Thank you very much for your time.
Hasta luego.
Merci. Bye.
Bye.
Okay. Uy.